Hi, my name is Raymond Hwang. I'm an orthopedic spine surgeon at New England Orthopedic and Spine Surgery and New England Baptist Hospital in Boston, Massachusetts. Today I'll be presenting a talk on the surgical treatment of common lumbar disorders. I'd like to provide a general overview of the common adult degenerative conditions that involve the lumbar spine. We'll review some of the basic anatomy, talk about the common problems, go through some of the evaluation techniques that I use, and also some of the treatment options. So we'll start with some anatomy. So to review, the lumbar spine is composed of 5 vertebrae, 5 discs, and 5 pairs of nerve roots. The primary function of the lumbar spine is to bear the weight of the upper body and the torso. It also provides primarily flexion and extension motion. There are numerous soft tissue structures that contribute to the stability of the lumbar spine, as well as provide controlled motion in addition to the bony structures. I want to focus on a couple of particular structures here. In this zoomed in cross-sectional view, we can see the facet joint clearly here along the posterior aspect. The facet joint is a true joint with a capsule and articular surface. The disc here, which we can see anteriorly, this is the neural foramen through which the nerve root exits the spinal canal. This area is the spinal canal through which the nerve roots descend from the thoracic spine. It's also useful to point out the soft tissue structures in this diagram. You can see the interspinous ligament, the supraspinous ligament posteriorly along the right side there. You can see the anterior longitudinal ligaments along the anterior surface of the vertebral bodies and the posterior longitudinal ligament along the posterior aspect. You can also see the ligamentum flavum along the posterior aspect of the spinal canal. This is a structure that is often hypertrophied during the degenerative process and can contribute to a number of symptoms for which patients will be candidates for surgery. Let's talk about some of the problems that adult patients face with degenerative lumbar conditions. As we probably all know, the vast majority of people will experience some significant low back pain at some point in their life. This is one of the most common reasons why patients seek medical care. It's the leading cause of disability in patients under 45 and can account for $30 to $55 billion of direct medical costs annually. Luckily, lumbar spine pain, low back pain does tend to resolve on its own. 80% of cases will resolve independently within the first 2 weeks. Unfortunately, most of these cases will recur within the next 2 years. Low back pain can result from a number of different structural pathology. This includes degenerative disc disease, spondylosis, muscle strain, muscle spasm, myofascial pain, as well as others. There are many different sources of pain and risk factors for developing low back pain. Unfortunately, it's oftentimes we're not able to identify the exact source of pain, although we do know there are several risk factors. One common one is smoking. This diagram here shows us where low back pain can be referred to. On the right, we obviously see pain that's located in the low back, and that's certainly very reasonable to call low back pain. But pain that actually comes from the lumbar structures can be referred to a much wider region, including sort of the greater lower back area, the buttocks, the hips, and even down the posterior thighs. When we talk about degenerative disc disease and spondylosis, this can manifest in, of course, low back pain. There's some characteristics that are often associated with this kind of problem. Radiation, again, into the buttocks and posterior thighs. Oftentimes, patients will complain of pain that worsens with certain activities, such as running, as well as prolonged standing or sitting. Myofascial pain, muscle spasm, or strain, as well as other soft tissue etiologies, are more commonly associated with tenderness to palpation. Of course, more than one of these can exist at the same time, which makes the diagnosis more complicated. It's also important to keep in mind that there are several non-spine related pathology that can contribute to low back pain. This includes renal, vascular, and other abdominal pathology. When we talk about degeneration or spondylosis, we're essentially talking about a phenomenon that's conceptually similar to arthritis. This is a very common finding within even asymptomatic individuals. It is age-related, so as we grow older, it's more commonly found. But the single biggest cause of spondylosis in any single individual appears to be genetics. but there are also other contributing factors, which include things like activity level, your occupation, any sports you may have played, trauma, as well as environmental exposures. Again, we know that patients who smoke tobacco are at higher risk of having low back pain or symptomatic spondylosis. We tend to think of degeneration as occurring in 4 steps, the first of which involves the disc. In this MRI, we can see 2 abnormal discs. On this T2 weighted image, normal discs should appear as the L2-3 disc appears, which is a high signal within the center portion or the nucleus, low signal along the annulus or outer portion, fairly tall disc height, and fairly flat contours along the front, the anterior aspect and the posterior aspect. The L3-4 and L4-5 discs here you can see are substantially different than the other discs. The early stages of degeneration begin with dehydration of the disc. Most normal discs are about 70% water, which accounts for the increased or high signal within the nucleus. In this image, you can see that the signal within the nucleus is almost as high as the signal of the CSF in the spinal canal. As the discs dehydrate, the disc will also lose some of its ability to support the vertical weight that it experiences. This can lead to loss of disc height, as we see in these 2 discs, as well as bulging of the non-water material of the disc. You can see at the L4-5 disc there is some posterior bulging. As this process occurs, patients will often experience abnormal motion within these discs, at least on a microscopic level. And this abnormal motion can be painful and can lead to additional or pathologic stress on the facet joints in the posterior aspect. In this image here, you can see the facet joints are highlighted in red. You can see that they've undergone some arthritic change here. The facet joints, like your knee joints, can undergo an arthritic process. And so when the abnormal motion of the disc occurs, the facet joints experience abnormal stress. They can develop arthritis. These arthritic changes can take the form of irregularities along the joint surface, enlargement of the joints, bone spurs, as well as cysts as well. When these cysts or spurs occupy space where otherwise nerves would like to occupy normally, this can lead to symptoms such as radiculopathy, in addition to the symptoms that may be associated with arthritis of the facet joints themselves. When we talk about disc herniation, this is a very nice depiction of what a disc herniation looks like. In this situation, you can see that there has been a tear in the outer annulus of the disc with essentially herniation of nucleus pulposus through that herniation. Not all symptomatic disc herniations need to be necessarily this extreme. Certainly a disc bulge itself without a tear in the annulus can cause compression upon the nerve root, as we see here, and it's not hard to imagine that this can be very painful, particularly along that nerve root. Symptoms that would be associated with this problem would be myotomal weakness and dermatomal pain and or numbness and tingling along the course of this specific nerve root. Spinal stenosis is essentially a higher degree of narrowing. In this picture, you can see that the central canal has been narrowed by a combination of a disc bulge as well as enlargements of the facet joints posteriorly. This problem can manifest itself either in the central canal or in the neuroforamen. Symptoms which may result would be neurogenic claudication. Neurogenic claudication primarily results from central stenosis and classically results in patients who complain of early or premature fatigue of the lower extremities as they start to walk. This usually occurs very reliably over a certain distance and is reproducible. It's usually relieved when patients sit down and then will allow them to start walking again a similar distance, after which they develop the symptoms again. Commonly, this can also be alleviated by forward flexion type positioning, so patients who will use a shopping cart will often say, I can walk further before I experience these symptoms. Walking uphill, using a bike, these also tend to be less susceptible to onset of these symptoms because of the forward flexion that's associated with these activities. This should be distinguished from vascular claudication, which typically does not improve with forward flexion type positioning. Depending on the location of stenosis, the same symptoms as you would expect from a disc herniation can occur: myotomal weakness, dermatomal pain, or paresthesias. Spondylolisthesis refers to the aberrant positioning of a vertebra over another. This is most commonly anterior, also known as anterolisthesis, but can occur laterally or posteriorly as well. The most common type of spondylolisthesis, especially in the adult population, is degenerative. Other types include isthmic, traumatic, pathologic, and dysplastic. The severity of spondylolisthesis is graded by the degree to which the bone has slipped. This is based on a percentage of the width of the bone below. Grade 1 is up to 25%. Grade 4 is up to 100%. Grade 5 would be a complete slip, also known as spondyloptosis. Spondylolisthesis can cause back pain as well as symptoms of spinal stenosis and nerve compression. Spondylolysis refers to a defect in the area of the posterior elements of a vertebral bone called the pars interarticularis. This is the region that spans the superior articular process down to the inferior articular process, as depicted here. This is most commonly seen at L5, and this is believed to be a result of the mechanical forces that this area experiences. The prevalence in the population is somewhere in the 5% range. It's typically either congenital or acquired very early in life. Sometimes it can be a result of a trauma as well. Luckily, most patients improve with non-surgical care. Typically, an acute spondylolysis would be treated with activity modification, a brace, followed by physical therapy. Rarely, surgical intervention can be undertaken. This may take the form of a direct surgical repair of the pars, but more commonly, a fusion is performed. So those are the most common types of lumbar pathology you'll see in the adult degenerative population. Let's talk briefly about the evaluation of these patients. In the office, obviously, a detailed history and physical are very important. I try to focus on the characteristics of the symptoms themselves quite a bit. Certainly the duration and the context in which these symptoms both began and continue to occur are important to understand, as are the treatment to date. Patients will obviously undergo a variety of different treatments prior to seeing a spine surgeon. It's important to understand both how patients responded to these treatments and also what was done prior. The examination is really critical to try to isolate where the underlying pathology is. As we've discussed, a lot of pathology can occur in the absence of symptoms. And so in a patient with diffuse pathology, it's important to try to isolate it as much as possible. The idea is to obviously provide the smallest possible surgery to achieve the biggest amount of symptomatic relief. The dermatomal map on the left here is very important. I actually have these hanging in my office so that I can actually show patients exactly what we would expect for certain nerve distributions. And the examination obviously is very important as well to try to determine which muscles may be affected. In doing the examination, before I look at the imaging, I try to have an idea of what could be responsible structurally for the patient's symptoms. In terms of diagnostics, there are several modalities available to us. X-rays, clearly the mainstay for initial evaluation. These X-rays are perhaps the best way to evaluate the overall or global alignment of the spine, as well as to evaluate dynamic instability, which may benefit from surgical intervention. CT scans provide very good detail of the osseous anatomy. This is useful in cases of patients who have undergone previous fusion or previous decompression to get a sense for the osseous anatomy in terms of surgical planning. MRI clearly preferred for its soft tissue definition. We'll often order gadolinium as well, which will provide additional delineation of any scar tissue, particularly around the neural elements, should the patient have undergone previous surgery. A CT myelogram is generally reserved for patients who are otherwise unable to have an MRI. This is a useful way to visualize the intrathecal contents and any stenosis that may be present. SPECT scans are used under certain circumstances, most commonly to identify active spondylolytic defects, tumors or infection, and sometimes fractures as well. An EMG and nerve conduction study are useful to differentiate spinal type nerve pathology versus peripheral. In the lumbar spine, it's useful to keep in mind the possibility of a perineal nerve compression. Along the fibular neck, the perineal nerve can be compressed and lead to symptoms that mimic an L4 or L5 distribution. it's useful to delineate that prior to undergoing an unnecessary spinal surgery. These are x-rays of a patient undergoing flexion and extension. On the right is an extension view where we can see the vertebral bones are fairly well aligned in the normal lumbar lordosis. On the left, we have the patient flexing, and we can see as a result of that flexing, the patient's L4 does appear to slip over the L5. It's hard to see when it's rotated like that, but if you rotate more vertically, you can see that difference there, and this may account for any pain that the patient may be experiencing. CT scan here demonstrates an L4 spondylolysis. MRI, again, this is a normal MRI that shows quite good detail of both the soft tissue as well as the neural anatomy. What we look for here are obviously patent central canal and neural foramen. This is a CT myelogram demonstrating stenosis at L4-5. You can see that with the myelogram, the intrathecal contents are pretty well demonstrated. I find it interesting that in this picture, in these images, the nerve roots within the canal are along the anterior aspect of the thecal sac, whereas on the MRI, on the posterior aspect, and this is due strictly to the positioning of the patient in which the MRI is performed in the supine position and the CT myelogram prone. This is a SPECT scan demonstrating a compression fracture. So that's the evaluation of the patient. What are the treatment options? Well, prior to any surgical intervention, for the most part, patients with adult degenerative lumbar conditions should undergo considerable conservative or non-surgical management prior to consideration of surgery. These fall into a few categories of treatment. These begin with activity modification, medications, which can include steroids or pain medication, physical medicine, which may in fact be the most important part of the overall care for the lumbar spine patient, includes physical therapy, chiropractic care, acupuncture, massage, as well as interventional pain management, which can take the form of epidural injections, nerve root blocks, facet blocks, or radiofrequency ablation. Luckily, most patients, the vast majority of patients, will improve with conservative care, and this emphasizes the need to pursue conservative care prior to surgery. Of course, this talk is about the surgical treatment, so I only have one slide on non-surgical treatment, but that does not reflect the importance of pursuing non-surgical treatment in these patients. In terms of surgical treatment, the primary indications are patients who are recalcitrant to conservative management for 2 to 6 months, depending on what the pathology is and what the symptoms are. Perhaps the best indications for surgical treatment in the adult degenerative population are patients with disc herniation with corresponding radiculopathy, lumbar stenosis with claudication and or radiculopathy, and spondylolisthesis with radiculopathy and or claudication, plus or minus back pain. A somewhat more urgent indication would be progressive neurologic deficit. An example of this would be foot drop or progressive weakness over a short period of time. This warrants timely surgery. And cauda equina syndrome, which would be the most urgent lumbar spine pathology. This typically is a syndrome that entails urinary retention with overflow incontinence, stool incontinence, and perineal or perianal paresthesias. This is a condition that does require fairly urgent surgical intervention, usually within 24 to 48 hours of onset, in an effort to maximize functional outcome. Patients who undergo surgery outside that window tend to do worse in terms of functional recovery. In terms of surgical treatment at a high level, this falls into 2 categories. The first of which is decompression, which focuses on relieving the pressure on the neural structures. This can occur either through a direct or indirect approach. In the image seen here, a L3-4 laminectomy has been performed with direct decompression of the spinal canal. Decompression of the neural foramina can also be performed through that opening. Indirect decompression can be performed by somehow altering the position or the angle of the bones using certain devices. The other category is a fusion, which can be performed either with or without hardware. The absence of hardware is referred to as non-instrumented or in situ fusion. Instrumented fusion typically is performed with a screw rod construct, sometimes with an interbody cage, but there are a variety of different implants that can be used to perform a fusion. This is an example of an interbody fusion that occurred between the two vertebral bodies here. Replacing the disc has been osseous bridging, presumably achieved through the placement of an interbody cage as well as bone graft. This provides an additional surface area for bony fusion to occur. So now we can look at some of the specific procedures performed based on the pathology. In general, for disc herniations in the lumbar spine, the procedure of choice is a microdiscectomy. On the sagittal MRI on the right, we can see an L5-S1 disc herniation. On the axial, we see that this occupies the right paracentral region or lateral recess at this level. On the left, you can see the S1 nerve root within the lateral recess without any compression. On the right, the S1 nerve root is almost not visible because of the degree of compression due to that disc herniation. So the goal of this procedure is to excise just the piece of disc that is occupying the lateral recess and compressing the nerve root. This can usually be done through a 1-inch incision in about an hour under a microscope. On the left here, we see a couple of pictures that depict this procedure and what's done structurally to the spine. In the bottom image, we see the laminotomy that's performed through resection of a small portion of the bone posteriorly. Through that defect, you can see the thecal sac as well as the traversing nerve root. That's retracted medially, and the disc herniation, which would be anterior to that, can then be excised, which we can see in the above two pictures. These disc herniations can, in fact, be quite large. This is a procedure that's typically a day surgery with a very good success rate. The vast majority of patients are able to sustain significant relief with their symptoms with this procedure. Post-operatively, patients typically are restricted in their activities. I advise patients to avoid heavy lifting, more than 5 or 10 pounds, as well as any unnecessary bending or twisting. This is an effort to try to minimize the chance of early recurrence of the disc herniation. After the surgery, there's a theoretically increased rate of recurrent disc herniations simply from the surgical manipulation that has to be performed. Patients often are able to return to desk work within the first couple of weeks. Patients with more physical type jobs may require 2 to 3 months worth of rehabilitation with physical therapy prior to returning to their jobs, but there are no long-term restrictions after this procedure. Here's a specific case of a patient recently, 36-year-old gentleman with 7 months worth of right thigh, calf, and foot pain that followed an L5 dermatome. His MRI demonstrated a disc herniation at L4-5. We can see here that this disc herniation does significantly compress that L5 nerve and occupies, in fact, most of the spinal canal. His pain was rated as a 7 to 8 out of 10. He was a maintenance worker and was recalcitrant to all conservative measures at that time. He elected to pursue a surgical intervention and underwent an L4-5 microdiscectomy. Depicted on the right is actually the disc herniation that was excised from during his surgery. He reported immediate improvement of his pain. In fact, in the PACU, he mentioned that his pain had resolved. At his first post-operative visit, he had a pain score of 0, and he was back to light duty work at 6 weeks and full duty at 12 weeks. And this is a not uncommon result from this kind of procedure. Patients with stenosis in general are candidates for laminectomy procedures. On the right, you see a patient with a very patent spinal canal, and here is an image of a patient with very tight stenosis, primarily due to ligamentum hypertrophy posteriorly. The laminectomy's goal is to decompress the central canal by resecting part of the facet joint, the ligamentum flavum, the disc, and the lamina, any structures that are imposing compression upon the neural structures. This can be done with a drill traditionally. More recently, newer technologies such as ultrasonic osteotomies can be performed, which provide more precise cutting and as well as a hemostatic effect along the cut bone. Here we have a depiction of the surgical procedure. On the left side, we see more of a surgeon's view of the anatomy, in which the posterior elements, the lamina and the spinous process, have been removed, exposing the spinal canal, and thecal sac. 80% of patients experience significant relief of their symptoms with this procedure. The incision size and surgical time varies based on the number of levels that are involved and the extent of the decompression. Single level procedures can be performed sometimes as a day procedure. Larger procedures typically require 1 or 2 days in the hospital. Postoperative care is similar to disc herniations. Typically, we restrict activities for the first 4 weeks primarily to allow the soft tissues to heal. Patients with desk jobs can typically return to work in about 3 to 4 weeks. Those with more physical jobs may take longer, but there aren't any long-term restrictions after successful rehabilitation. Here's a case of a gentleman, 76 years old, with 6 months of thigh and calf fatigue after walking more than half a block. So he presented with neurogenic claudication. His MRI demonstrated L3-4 and L4-5 stenosis. You can see at the L2-3 level, the canal is patent. We also see bunching of the nerve roots, cephalad, to the 2 levels of stenosis, and this is commonly seen as a result of the narrowing more distally. This patient elected to pursue surgery. He underwent an L3 to L5 laminectomy. He was able to return to normal activities within 10 weeks. His leg fatigue improved significantly, and he was able to walk much longer distances. For spondylolisthesis, typically a fusion is performed. Fusion, again, is an attempt to create osseous bridging between 2 or more vertebrae. This is performed when stabilization of the spine is required. Usually, in the setting of spondylolisthesis, a decompression is performed. So this fusion is usually performed in conjunction with the decompression. And instrumentation is used to increase the rate of fusion. When we talk about instrumentation, these are the screws that are traditionally used. Depicted here are pedicle screws and the rod construct used across them. They're placed within the bone, as seen on the right here, and connected between levels using the rods. Without instrumentation, the fusion can also be performed in a non-instrumented manner. This is typically done through the use of bone graft. We can see here on the left traditional placement of the bone graft and a posterior spinal fusion along the posterior lateral gutters or the intertransverse area. This allows or facilitates bony bridging across the bones. In a year, our expectation is that solid bony bridging would have occurred across the area where the bone graft was applied. Oftentimes, bone graft is used autologously in conjunction with bone graft substitutes as well as other extenders, which can help increase the rate of fusion or decrease the need to harvest autologous bone. Cages can be placed within the inner body for 2 main purposes, the first of which is to increase disc height. You can see on the left radiograph that this patient has spondylolisthesis as well as collapse of this disc. The area depicted in blue is the neuroforamen. You can see that that area is fairly reduced compared to the one cephalad to it. By applying a cage into the intervertebral space, we're able to increase the intervertebral disc height as seen in the right radiograph. And by doing so, the neuroforamen can also be increased in height, which can indirectly decompress the nerve root that's exiting through there. So this is one of the common ways to indirectly decompress a stenotic neuroforamen. The other main reason to perform an interbody fusion is to increase the fusion rate. By performing interbody fusion, you're adding another surface to which fusion can occur, which is believed to increase fusion rates. When it comes to fusion, it's a very general term. There are a variety of surgical approaches, anterior, lateral, and posterior, with subtleties, subtle variations to each of these, as well as a variety of different implants that can be used. The length of the incision, the type of surgery, and the hospitalization all depend on the extent of pathology and the number of levels that have to be addressed. Most fusion procedures require about 3 to 4 days in the hospital, but most patients can return to normal activities within 3 to 6 months. This is a case of a patient with spondylolisthesis. She's a 68-year-old female who presented with 18 months worth of low back pain, bilateral thigh, calf, and foot pain that she rated as a 10 out of 10. On her MRI, we can see that she does have spondylolisthesis at L3-4 with fairly tight stenosis. secondary to unroofing and bulging of the disc below, as well as hypertrophy of the elements posteriorly. This is her axial image here at that level. Her symptoms persisted despite non-surgical treatment, and she elected to pursue surgery. She underwent an L3-5 laminectomy and fusion, seen here in these radiographs. Her back pain improved and her lower extremity pain resolved. She was able to return to all activities, including work as a radiology tech at 6 months. So in summary, luckily, most low back-related symptoms improve without surgery. Patients with nerve compression or instability may benefit from surgery if non-surgical treatment fails. Lumbar decompression and or fusion can provide good relief of symptoms and allow return to activities. Thank you.